Well, I hope you understand me. Thank you very much for inviting me to this beautiful country. Thank you, Dr. Yes, for the program and the president, and I see our president of America. So I'm going to share some of the thoughts on, first on the elbow, what you do on post-traumatic elbow contraction. Sorry. This is just these are my disclosures in the United States. They're very excited about that. I don't own anything, and no one pays me to do anything. I wish. So we started with elbow arthroscopy. Dr. Watanabe, a long time ago in the knee, told us we can do this, and he is really the father of that. So the advantages for doing arthroscopic work is you can really see the whole elbow, and it's so technically demanding, and so we have to be careful when we go inside not to make mistakes. Most contractures in patients are mild, and they're usually well tolerated. We only need 30 to 130 degrees, and supination and pronation 50-50. Please remember in the elbow that terminal flexion, because of cell phones, is now more important than extension. In the knee, extension is much more important. You're going to see plenty of videos of how to do this, and I'm going to show you. So when you think about the exceptions, if you have these patients are basketball players in the United States, and here, gymnasts need extension, and weightlifters need it. For flexion, a woman can't fix her hair if they don't have it, and males can't shave or tie, and so it becomes very important to know how to do this. On all the procedures of the elbow, I like to classify them as they get harder. The ones we're going to talk about today, I was asked to speak about, I think are one of the harder ones to do, rather than some of the easier ones, the complexity. This is a patient here, right now in the United States, everyone wants to know, is it evidence-based? Do we have science to prove things? I'm here to tell you that arthroscopy to release post-traumatic elbow in the literature doesn't exist. It's very poor in evidence-based. It's fair quality if you have rheumatoid arthritis or tennis elbow, but not for young patients. There's no science. On the other hand, there's poor quality evidence to take out the radial head, and I'm going to show you how to do that arthroscopically as well. But here's a patient that they put in the radial head, and she has no motion, she has no supination, no pronation, because they put in a radial head too big. So sometimes doing what you think is right is not always right. Here, on the other hand, in this elbow dislocation, and we just heard about the terrible triad, here, this person, we took out their radial head, and look how good the motion is. So the belief always to not take out the radial head is not true. If they don't have wrist pain, you can take out sometimes the radial head and get a much faster and better result, whether you do it open or, as I'm going to show you, arthroscopically. Primary arthritis in the elbow is very rare, so we're going to talk about post-traumatic things, from elbow dislocations, fractures, and trauma, valgus extension overload. There are many reasons. Look at the bird getting crushed in the baseball game in the U.S. So there are many reasons to do release. There could be intrinsic problems, and I want you to do it arthroscopically if you have any of those, as we did today. But if you have extrinsic reasons for a contracture, like heterotopic bone, although we're playing around with it, myositis or muscle contractions, you need to do an open release. How do we know? This is an arthroscopic picture of a fracture right now that I'm going to reduce inside of the capitellum and the trochanter groove. Does this work? In 20 years, is this going to be okay? I got lucky. Here's her result, but not every time. Because post-traumatic stiffness is like playing golf. That's a bad shot, and it's functionally pretty demanding. And so I'd like you to think about it. To do it, arthroscopically debride, and when you do it, I'm going to show you, I'd like you also to take out that radial head. It starts with taking out loose bodies, and so if you can find a patient that has some loose fragments or some loose bodies in the joint, I encourage you, that's a perfect case to go in, take out the loose bodies, and go home. You can see here in the CAT scan the loose bodies. If you look at it, though, in the literature, for a study showing primary osteoarthritis here, they actually proved that back, I think this was in 2000, that open procedure gave better range of motion than arthroscopic, but arthroscopic gave better pain relief. I think that's because in 2000 we didn't learn as much on how to do the procedure. But this study showed no statistical significance whether you do it open or arthroscopically, overall range of motion and pain relief. And in fact, the arthroscopic ones had neurological dysfunction in some paratopic bone. Then other studies came later, in 2006, where they talked about radial head resections. And it turns out that you don't have to do what we call that KO procedure, I'll show you. You just have to take out the radial head and you'll get better range of motion. This is a picture to show, this is the open KO procedure, the only humeral arthroplasty, if you haven't seen it, that you can do arthroscopically, but unless you have a rheumatoid arthritis, you really don't need to do that, and in fact, it makes the procedure longer and more complicated. Who do you do a release on? I would recommend if you have patients that can't extend the last 40 degrees, and for patients that can't flex 105 or above, those are the patients I want you to think about doing releases on. The history is you have to read the previous operative report. They probably have had trauma with plates and screws, and you want to know if there's infection involved or what's going on, but especially if the ulnar nerve was affected. So if arthroscopically you do something, you know what you're doing. Because your summary plan is to get rid of pain, get rid of stiffness, and solve instability. So if you have pain at terminal motion, all you have to do that's impingement is you want to take care of the back of the elbow. If on the other hand you have pain throughout the whole arc of motion, and you have night pain or effusions or stiffness, think about arthritis throughout the whole joint. And if you have pain at rest, that's someone you don't want to operate on because probably they have an infection or maybe spine disease or something else, and you won't get the result that you want. You want to make sure on the physical exam what the arc of motion is and compare it to the other side. If the patient has a limited range of motion on the normal side, then you know you don't have as big a job to do for whatever reason. You want to look at that ulnar nerve because it's very important to know, is it irritable, is it subluxing, is it dislocated. This is an x-ray, it's a good point. You want to take good x-rays because if you look up above in this cubital tunnel view up here, that's a piece of bone that's sticking in the cubital tunnel, and all you have to do to solve this person's problem is take that piece of bone out. You can't do that arthroscopically right with the nerve, and you solve the problem. So x-rays are important. CAT scans are important to see the loose bodies, as you see, and I don't use an MRI routinely for this. Young patients, non-operatively, if you want, they have to have braces. We use the anti-inflammatories just like all the exhibits show. We can use injections, and therapy braces, but this talk is going to be more right now on surgery. So in the operating room, I go lateral decubitus in the position. You can go supine or prone. And what I want to do is I'm going to show you some of the pictures now. I'm going to start with removing the osteophytes, and then I'm going to take away the capsule. And sometimes I get the posterior bundle of the medial collateral ligament, not the anterior bundle. And then if they have no more than 90 degrees of flexion, I will first release the ulnar nerve to pull it out of the way before I put in the arthroscope so I know where it is and so I don't make a mistake. I position the patient first. I insufflate with 15 cc's of normal saline. I'm going to look from the medial side proximally, and I'm going to work from the lateral side to first do the synovecomy. Then I'm going to go to the radiocapitellar joint, and then I'm going to take away the coronoid spur. Then I'm going to switch, as you'll see in a second, and I'm going to view from the lateral side. Then I'll work from the medial side, and then I'll go to the back of the elbow to take away the electron spur. And I put the shaver, as it says, right in the middle, and I look from the outside. And then I consider doing the electron when I said fenestration, breaking that hole in the KO, the humeral. And last, I take with an osteotomy and electron tip. So here you can see that we're going to work now first reviewing from the portal on the lateral side, and I'm working from the medial side, and I'm taking my shaver slowly with just a little suction, and I'm going to expose what I need to get to the capsule. I'm going to take the coronoid off first, and then the trochlear root. You want to start in the lab with cadavers, but afterwards you want to see if you can do this, obviously, in the operating room. And maybe you work only for a half hour, and then you open, and you slowly progress to get better. There's many reasons to go, as I said, open and then intrinsically. But the point is that if you're not comfortable, then do it open like this. Here, you can see preoperatively they can't move, and postoperatively, open, you can get a good result. Here as well, another patient open. But I want to show you now, if you start with a synoviectomy, and you take that capsule away, as long as you see the brachialis, the red muscle, that's when you stop. So here you can see we're coming in now to clean up with not a lot of suction, and we're going to first start by taking anything on that area that's white to get to the brachialis muscle. We're working from that proximal portal here. Proximal, working from the lateral side. I'm going to take all that thick capsule that we have to cut away. And sometimes it's easier to use a cutting device like a punch rather than a shaver if you don't feel comfortable using that shaver. And you just methodically stay here. It's true that you have to work hard and fast. That's why I'm saying give yourself a time to practice. Time's up, then convert to the open and see how far you can get to do the whole case arthroscopically. I'm going to switch sides and then slowly expose the bone. And you'll see that when I expose the bone then and come around, I can get to every section to expose that brachialis. As you can see, when my tourniquet was on too long, so now I turn it down to continue working. So it's hard. He has a problem, this young man. It's a steep learning curve, and you want to make sure that you don't crash and burn. So I encourage you to start slow and then figure it out, because the posterior osseous nerve is there, and you have to know what you're doing with the anatomy. For the throwers that get valgus extension overload, those are the patients or someone who plays tennis who says, I can't serve when I get my arms straight, or when I throw the ball at the full return of the ball, it hurts in the back of my elbow. This is another case where arthroscopically we can release. You can use anti-inflammatories again. You can rest it, but I'm telling you, it just won't work out all the time, and it's better to release it. These are the patients that look like this, where the x-ray is. They have arthritis, and they have these posteromedial osteophytes near the ulnar nerve that you have to release. Here you can see diagrammatically, I'm going to release with an osteotome arthroscopically just the tip of the electrode so they can fully extend as well as get posteromedial osteophytes. But more fun now is the radial head. What do you do with that radial head that comes out? It's so common, we see it all the time. I'm telling you that studies have been shown that, yes, if you take a radial head, you can transfer the force transmission, but here's a study, 15-year follow-up, that yes, they had arthritis, but 92% were satisfied, and they were less than 40 years old, and they got back to doing activities rather than on fixing all these radial heads all the time. So in convoluted radial heads, here grade 2 or higher, you can see early excision is a viable option after a displaced and convoluted fracture. And you can get them back for quick recovery, so maybe take it out arthroscopically. So here's a 3-4 that I'm going to tell you you can excise as long as the medial collateral ligament is intact and the wrist doesn't have pain. Here's a gentleman that came in. This is his x-ray. This is his CAT scan. He has arthritis, post-traumatic, and he can't move that elbow. He can't extend, flex, and he can't really supinate or pronate. So we decided to take out the radial head. So it's from the proximal medial portal, and now you go into the soft spot this time. Right. And what you're going to see is, if you look, we're going to expose again the bone, having done the capsulectomy. And here you can see the radial head. And you can see how arthritic it is, so I have to get rid of the synovitis. I'm clearing it. And then I'm going to literally use a burr. You'll see the shade down the radial head. Here again, the radial head, here in the back. And so, as we do that, to expose it, then we switch portals. You'll see. And as we switch portals, you can now see that I come from the back, and this is me turning the radial head. And I think it's like shoulders. We used to take a lot of distal clavicle, 2 centimeters, and now we only take 5 or so, or 6 centimeters. Well, same thing with the radial head. You don't need a lot, and so you still have stability. You don't have to go to the annular ligament, and you can get really a nice result by taking the burr, here it is, in the back, and kind of like a cutting block, like we do in the shoulder, which comes right across that radial head. And so I think you should, again, go to the lab first, but I think you'll see that it's not as hard as it looks. So here he is. I do use braces. This is one of the new braces called the Jazz brace. I think it's great because they can put it on, keep the motion, flexion and extension at night. He wears it for 6 weeks so he doesn't get contractures with anti-inflammatories. And here he is now again, comes back into the office. And so he's going to show us his stuff. There's the radial head. Not a lot resected, you see. And now he's going to go all the way up to where he wants, as well as now he can extend his elbow all the way, supinate and pronate for us. So that's pretty good, without a lot of swelling. Don't forget about complications neurologically. There are major injuries. They're not reported in the literature, but they're there. People have cut arteries, cut nerves. I don't think they have it. And so that's why you want to practice first and then try as much as you can before you do it or visit people. This is my daughter when she's 4 years old. I say I'm very happy to come here so that we can share our thoughts as I listen to some of your lectures. We need to share more medicine together. We have a crisis in the United States. Doctors are not nice to each other. It's really terrible. And so we're trying to be a lot nicer to each other as we share these thoughts. So, gracias, thank you very much. And you have to just try to trust me for a little while when making visits on the bus. We're going to talk about posterior shoulder pain now. Very different topic. These are again like disclosures. What do you do when this 24-year-old woman comes to the office? She's a tennis player. She has no illnesses. There are no tricks, no trauma. Since age 9, she's been weak. She really can't externally rotate. Every doctor said there's nothing you can do. That's what you see in the back of her scapula. And multiple opinions say, don't worry about it, it's going to get better. Well, if you turn out and do the EMG, it turns out that our suprascapular nerve is involved only in the infraspinatus. And now we don't feel so comfortable because we don't do that all the time, or we don't know what to do. Well, I'm going to show you today how you can only arthroscopically fix this and help a lot of these people that are out there. And this disease has been seeing you, but we never look. Sometimes we don't even take off the shirt to take a look. And you'll see, because it hurts in the back, and you say, oh, you have a pain problem, go to a pain management doctor. So I'm here to tell you that posterior shoulder pain is wrongly attributed to rotator cuff disease and neck disease. And why is it? Because we feel comfortable diagnosing neck disease. We feel comfortable diagnosing rotator cuff disease. But when you have atrophy, especially in the infraspinatus, if you delay treating it, it will never get better. It's kind of like a lady that comes in with a carpal tunnel and there's no muscle here, the APB. She's 85 years old and says, I didn't do anything, and yesterday it just started hurting. And you know that's been that way for 20 years. And you can get rid of her pain, but you can't get that muscle back. So you want to intervene early. I'm not going to talk about these are my patients in the emergency room or dislocations. That's not the kind of posterior shoulder pain that we want to talk about together. You like the knife? Oh, sorry. This is what I deal with in New York. It's when the patient has posterior and lateral pain. It can be dull, it can be sharp, it can be burning. It could be an overhead worker, someone that works overhead as workers' comp, or someone that plays volleyball or baseball or something. I want you to think about it because it sounds like it's going to be rotator cuff disease, but it's not rotator cuff disease. They'll be weak in external rotation. So you have to rule out the diseases of rotator cuff, instability. You can look on And it's the most common diagnosis in athletes that's seen today, that chronic ache in the back of their shoulder. Remember that the suprascapular nerve is not just motor, it's sensory as well. It has a branch that goes to the AC joint, and people forget about that. This is the suprascapular nerve you see right here. It travels down the neck towards the transverse scapular ligament. Remember, the nerve goes underneath, the artery goes on top. And then it can be compressed in two places, either at the transverse scapular ligament or at the spinal ligament. If it's at the suprascapular notch, you're going to find that it's 3 centimeters medial to the AC joint. The nerve enters the suprascapular notch of the transverse scapular ligament, and it gives off branches to the supraspinatus and then that AC joint. It hypertrophies sometimes, and when it narrows down to that area, you get atrophy at the supraspinatus and the infraspinatus. If it's compressed down low, you're going to get atrophy only at the infraspinatus, and in fact, because that ligament works to tighten, when someone throws a ball, it tightens on that nerve down low, so on internal rotation, that's when patients complain, or throwers, baseball throwers complain. Here, courtesy of Laurent, let's travel down the suprascapular nerve underneath the transverse scapular ligament, come curving around to go medially. And you'll see that the key is it's away from the glenohumeral joint. That's why we can operate on it, because there's nothing bad that you're going to hit. And see how it curves all the way towards the body, away from the glenohumeral joint. But it's not new. I'm not telling you anything magical. In 1959, in the New England Journal of Medicine, people wrote about it, but like always, things get buried inside the literature, and we forgot about it. It can be idiopathic, it can be from direct trauma, it can be even from a retracted massive rotator cuff tear or some ganglion that's sitting there. This is what it would look like if they have supraspinatus and infraspinatus atrophy in the back of the shoulder. And here would be just infraspinatus atrophy. Motion's good, and that's the problem. The patient says, well, it aches a little, so you feel you don't need to do anything. But when you have that atrophy, they need you to do something soon, not wait. It won't get better. So on physical exam, I ask you to do a cross-guard abduction test. If the x-ray doesn't show arthritis of the distal clavicle, and they have pain in the back of the shoulder, it's not a distal clavicle problem. It's a suprascapular nerve problem. And that's what we have to start thinking about. The Germans taught us that it's not the space that we do when we take away the clavicle. We're actually denervating the nerve when we do a distal clavicle resection. That's why people get better when you do an AC joint resection. Here on MRI, you can see some of the wasting of the supraspinatus, if you look, right above, or fat atrophy with the ganglion. If you have that, that's great. Then you know the disease that you're dealing with. That makes it easy. But when I went to Asia, I learned women use the umbrella when it's sunny. I always thought you use the umbrella when it's raining. So not everything is always true. So if you get an EMG, I'm telling you it has a low accuracy. It's a dynamic nerve. So just because we know the numbers should be normal, even if they're normal, I'm telling you, just like this bad golf shot again, it's like cubital tunnel. We operate on people with elbow problems with their ulnar nerve cubital tunnel with a negative EMG. I need you to think about it when you've made the diagnosis as well with a normal EMG. Because it's hard lifting this lady with this young man. So this is one of these diagnoses that I don't want you to do physical therapy if there's atrophy in the back of the shoulder. I want you to think about operative intervention. It's not going to get better. Yes, they're tight in posterior capsule things, and you can do some of that stretching, but you're going to need to do something about it. Open surgery has been done, but it's so hard because it's a small hole. So I'd like to show you now arthroscopically. This is a left shoulder. Your arthroscope is going to be placed in the lateral portal. You're going to find the CA ligament. We're going to travel on the CA ligament in the shoulder, down to the coracoid, and we're going to keep the supraspinatus muscle anterior. And once we catch the coracoid, we're going to find the conoid base, and then 3 centimeters medial to the AC joint, we're going to stick a needle or a dull trocar, and lo and behold, we're going to see that suprascapular nerve represented there and the transverse ligament. And then all we have to do is protect the nerve and cut the transverse scapular ligament right across, just like that, and now the nerve is free. Here, if you have someone with supraspinatus and inflammatory atrophy, an EMG that's positive and EMG is negative after you cut it, the ligament, you're going to be a happy person. This is the perfect first patient you want to try it on. What about massive rotator? You see that on the top part, what happens is this ligament changes position from vertical to horizontal to squeeze the nerve to crush it as it's sitting there. And so they have pain based on those. And we tested it with a vulvometer to see how tight it gets, and it gets so tight inside. So here's our semi-pro tennis player. I hope you're starting to think about what we're going to do for her. So here's the take-home point in your office. If you put a needle 4 centimeters medial to the posterolateral corner of the spine of the scapula, that's the spinophalangeal ligament, and inject 10 cc's of lidocaine, just like you would for a near impingement test for a shoulder. Their pain is going to go away when you do that cross-arm adduction test. And now suddenly you've diagnosed compression of the infraspinatus down below. Here you can see you can do your posterior stabilization and your shrugs, but it's not going to get it better. So here I'll finish up and show you now. If you go to the operating room and we put 2 portals, one 4 centimeters, one 8 centimeters, from the posterolateral corner of the shoulder, here they are. We're going to go inside, and first what we did when we experimented in the lab, we did it closed, so I don't really care. That's the spine of the scapula. It just shows me that the nerve is there. So now, this is if you did a beach chair position, and you see that the scope is in the regular position, and then to the right, it's in the 2 portals, 4 and 8 centimeters to release the spinophalangeal ligament. Think of this like the knee with a ligamentum mucosa, or the, if you call it an infrapatellar plica. This structure is thick, and it's attached to the top part of the arch. When you do ACLs, you know that you have an ACL below the infrapatellar plica, so just take everything that's above in the arch. And big people have big ones like this one. And this again, pulling back on the spine of the scapula, he's the suprascapular nerve that's exposed. The infraspinatus is pulled back because we're in the back of the shoulder, and the supraspinatus is over to the right. And in little people, it's very thin. Here you can see up above the white. That's all we take off the spine of the scapula in the right shoulder. You're looking from the back. And on the bottom, I'm going to take my trocar, and I'm going to take the shaver, and then suddenly you'll see that medially, this is the, now it's gone, the arch is open. And on here on the left side, you'll suddenly see it come into view because it hugs medially, as we saw in that cartoon. Here comes the nerve. The nerve is exposed right there. And that's all you have to do. I would do it first before you do anything else in the shoulder, by the way. Here again, the nerve. Sorry, I'm trying to advance it. And so you release it. Sometimes it has 2 branches, but it's always on the inside immediately. And here's the double nerve. It doesn't matter, you're nowhere there. Here's your MRI. If there's a ganglion cyst, you can go in the labrum. Some people like to take the cyst out at 7 o'clock. But if you don't release the spinophalangeal ligament, it's not going to get it better. But there you can see the juice from the ganglion, so why not stick a needle in the back? You can take the ganglion out right there. Then it's easy to get them back because you didn't do any open surgery, so you can strengthen them and get them back playing their sport. So here's our 24-year-old again. I hope now you're going to consider either visiting or doing something to release that spinal gland ligament because her pain did go away. So when you see an overhead athlete, when they fail conservative treatment, I'd like you to consider going into the back of the shoulder. Have it in your diagnosis. It's been seeing you. You haven't been seeing it. This is a bridge that these people in the Midwest thought would be perfect. It's far from perfect. I think we're a lot smarter. Go to the lab, practice with your throwers, your weightlifters, your basketball, your laborers, your softball throwers. It's been in the literature. A very famous surgeon in 1987 said that the first surgery in the hope that posterior shoulder pain will go away and that full function will be preserved is just not a smart idea. I thank you again on behalf of my daughter. When she was 4, she's now 20. I don't know what was in her brain when she went to greet this other person in her mush brain, but she was hugging them. I hope we can share a lot of things together in the future. Thank you very much, guys.
Bien, en vista del tiempo que tenemos, hay espacio para 1 o 2 preguntas para el doctor Plancher. ¿Alguien de ustedes quisiera hacer alguna pregunta o comentario? Ya, bueno, tengo una pregunta yo, nada más. ¿Qué tan frecuente es la incidencia